So, hi everyone. I want to welcome you all back. My name is Targownik. Hopefully, most of you have seen the first part of the episode where I interviewed Dr. Gordon Guyot. And because this is sort of a very important topic in the trans discourse, particularly as it applies to the differing attitudes about pediatric gender affirming care, or pediatric medical transition, and some of the controversies around it, I wanted to reach out to some people who I've had conversations with in various in various contexts, who I think represent a different variety of views on pediatric gender medicine, to have a bit of a conversation about sort of what's been happening in the past few weeks regarding the systematic reviews that were published by Dr. Guyot and others at McMaster University, and as well as some of the larger conversation around sort of the political impact this has had. And so joining me today on our podcast, I want to introduce you to three different people. Or what I'm going to do is actually let them introduce themselves, because they all are people of some esteem in this area. So I'm just going to start from and do this sort of in alphabetical order. And starting from my top left, I have Dr. Tyler Black. So Dr. Black, maybe just tell me a little bit about why you're here.
Sure. So my name is Tyler Black. I'm a psychiatrist. I work specifically with children and adolescents. I'm an emergency psychiatrist. I've been on your podcast before to discuss clinically dealing with kids with gender affirming care, though I don't provide it myself. And I'm on Twitter at TylerBlack32 if people want to find me.
Excellent. And to my bottom left, we're also joined today by Dr. Gideon Meyerowitz-Katz.
Hey, yeah, I'm Gideon Meyerowitz-Katz. I'm an epidemiologist and I guess science communicator. My main areas of work, I did work during COVID on infectious disease, but otherwise I mostly work in chronic diseases. And I write a blog, which you can find these days on Substack and Medium, Health Nerd, and I'm also on Blue Sky and Threads. I'm no longer really on Twitter, unfortunately, these days.
Understandable to some extent. And then just under me, I've got Adam Zivo.
Sure. So I'm Adam Zivo. I'm a columnist and journalist with the National Post, which is one of Canada's two national newspapers. I used to write quite extensively on pediatric gender care about a year or two ago, but because I have a number of different beats, I haven't been on the ball on that subject more recently. So I'm a little bit out of the loop when it comes to recent developments, but I can provide some level of analysis on the larger political context surrounding this conversation. Now, I do want to clarify that I don't have a background in, like, I don't have any medical training whatsoever. I do have a public policy master's degree, so I'm not totally illiterate when it comes to statistical analysis and understanding the quality of different forms of evidence. But, that has its limitations.
So, of course, the reason I have you all on is because I think you all have spoken publicly in some regard, whether on Twitter, in newspaper, or other fora, about pediatric gender medicine. And I think all of you have different sort of views that sort of span across the political divide with sort of different opinions. But I think the greater context, I think you all speak not from a sort of from a very reasoned perspective, no matter which side you take of it. So I wanted to start, the conversation just about, for my conversation with Dr. Guyot today, is sort of, something I think all of us do to some point, which is how do we translate science into, how do we present science to the public? And I think this is where sort of some of the controversies come up. So one of the things that has come out of this is sort of this disconnect between how scientists talk to each other and how scientists communicate with the public. And I think Dr. Guyot sort of ran into this sort of headlong when he entered the pediatric gender debate. So one of the challenges, one of the challenges that I found with this is that when speaking to scientists, we speak in a certain way, and when speaking to a public, particularly in a controversial topic, it's often very difficult to explain things. And what I really want to focus on here is particularly in regards to how we discuss things like the strength of the evidence. So in this, in Dr. Guyot's quote, he talks about this concept of when we don't have good evidence, which is what the basic conclusions of his papers were. of the systematic reviews, or when you look at pediatric medical care, is that we default, in a sense, to a combination of our clinical expertise, of our patients' values and preferences, and basically let the patients guide their way to some extent. Now, I want to start with Adam here, just because I know he's sort of someone who stands a little bit in opposition to where I stand on this. What are some of the challenges what are some of the reasons why people sort of who are on, let's say, the more conservative side of the spectrum tend to back away from this framing?
Well, I think that there's a deficit of trust here because for many conservatives, they recall that not so recently, not so long ago, they were told that the science was settled here. And they were told that if they questioned the science, that they were committing genocide against trans people and that they should be excommunicated from the public discourse. And so there's still a residual bitterness around that. And when one tries to frame the conversation in a moderate way and to acknowledge the limitations of the current evidence base, but to talk about the fact that sometimes pediatric gender care can be useful, or at least could be something that some people might want to explore, they're obviously going to react in a hostile way. And you talk about, for example, the importance of respecting patient autonomy. Well, conservatives are going to respond to that by pointing out the fact that patients aren't coming in as blank slates, right? So let's say you have a patient who's coming in who has to make a decision about cancer treatments. They're not going to have many preconceived notions about what treatment they should take. They might do a bit of their own research, but for the most part, they're going to trust you. You'll guide them through this process, and then they'll make a decision to the best of their ability, given this information that you've provided. But if you have a kid who's coming in and they are presenting as gender dysphoric, they are almost certainly going to be aware of the conversation around trans rights, around pediatric gender care. They may have been coached about what they should say in order to get hormones. They may have already made up their mind about what kind of treatment option they want, regardless of what you advise. I mean, that's something that was widely reported upon in Hannah Barnes's Time to Think, which is a book that, interviewed 60 gender clinicians in Tavistock, in the UK. So we know that that's a problem. So if you just defer to patient autonomy without considering the larger cultural and political context, you're not going to be able to persuade people because it won't be perceived as genuine.
So like Tyler, you're a clinician in practice, and I know you haven't mentioned you're not the one who necessarily prescribes the different components of gender affirming care, but in response to what Adam is saying, because this does ring true, to some extent, patients do come in, especially young children, like they're not coming in as a blank slate. They often have a preconceived notion of the kind of care they want to receive, and I do agree to some extent that there has been a shift in our understanding of things to the point where we once firmly believed that if you felt this way, that this care was going to be beneficial the vast majority of the time. And we're now entering a landscape where I think we're less certain about that. And we're probably less certain about it in certain clinical contexts, especially maybe for needle females, maybe for people whose symptoms are becoming more apparent in adolescence, that this may not be sort of a slam dunk as we once believed. Even if, how do we, what is your response to something like this when patients are coming in with a preconceived notion or preconceived set of desires about wanting something that may or may not be the best for them?
It's a really good point. It's not unique to gender care. Like I understand what Adam's saying, but I'm a child and adolescent psychiatrist. I think every family and child I've ever seen has come in with some notion of what they'd like to see happen. I've had kids come in requesting to be admitted to hospital, requesting medications, requesting certain therapies, requesting even certain therapists. So, it happens outside of gender care, and it happens in gender care, that people have a climate around them that informs what their options are. Our jobs as professionals is not to mimic what's being said in society. In fact, what we try and do, and what I try and do in child psychiatry, is be quite subversive to what parents are saying. Like, I bring up things that aren't being talked about. I bring up things that aren't being mentioned. I ask about questions that haven't been thought of. The kid who comes in and says, I think I'm depressed. And I talk to them for a really long time. And I actually think that anxiety is at the root of most of their mood issues. And while they do have some depressive symptoms, anxiety is the diagnosis. They came in asking for depression, and I'm leaving them with anxiety treatments. So when this happens, it's our job as professionals to assess the clinical situation, to explain what we think is happening, because the first part of informed consent is information on what we think the diagnosis is. And then it's translating into, here's what we know, here's what you can do. For example, offering puberty blockers to people. It's not offered under the guise of this will make you feel better or this will not make you feel better. This will stop your puberty. That's what puberty blockers do. They stop puberty. So when it's offered to a kid, it's not offered under the guise of, after you do this, all of your problems will go away. It's on the guide of, here's what we know about stopping puberty, for example. So these discussions have to be had at a really individual level, taking into account what the diagnosis is, but also recognizing that, we live in a society that's going to have lots of expectations. Doctors are expected to be professionals and give the best information they have.
So this raises a very interesting point, because, if I listen to some of the arguments coming out of people who are more critical, one of the things they pick up on, and I think this is, to the extent that it's true, I don't know, but I'm sure it certainly happens, is that I think a lot of the, there's a perception that a lot of the clinicians who provide gender affirming care are in the tank to some extent to transitioning children. And when they were presenting, a lot of the, and I recognize a lot of this anecdotal, is that people are told things like, and I think this comes back to what Adam was saying about these issues of distrust, that if you don't do this, and I know we've talked about this before, that these lines that come up again in the media, like, would you rather have a live son or a dead daughter? Would you rather, this is life-saving care, and so the reason this comes up is, we talk about informed consent, but how do we build that level of trust again, that physicians who are going to be providing this care in whatever context are truly providing both the pros and the cons, or the theoretical pros and the cons, or presenting the uncertainty of what we know and what we don't know. Like, every physician is, in a sense, their own independent actor. We don't have, it's not regimented, it's not standardized. Everybody can go on script or off script. What are the ways that how do we want to build trust? And I'll just leave this open for anyone who wants to think about it. How can we build trust in the system that the information we're providing is dispassionate, is objective, doesn't put their foot up their hand, the finger on the scale on one side or another?
I'll quickly, it's a great, I actually have a question for Gideon about this as well, because I know he does a lot of public health analysis, but people do trust their doctors. Like, this idea that there isn't trust, it always applies to a generic doctor, but when you ask people about their own doctors, they always say, I trust my doctor. People go to their doctors in trust. Doctors are among the most trusted people in professionals in people's lives. And certainly the online rhetoric would not believe that. The way that pundits talk about it, you wouldn't believe that. Even in surveys, this is the classic survey question, is, do you think that doctors are good or bad, or do you trust doctors? The number is much lower than, do you trust your own doctor? So doctors come in with a position of trust, and our job is to do what we do competently. I can't deny what people say on or off script. I'm not here to dissuade every story that's ever been told, but I know that good pediatric gender care is not pushing someone to a conclusion. It's giving someone options. I've seen hundreds of kids who do not transition with gender issues, whether it's gender dysphoria or gender questioning, and they go on to live happy lives. So there aren't that many clinicians that I know of in this space, and I work in, BC, which is a relatively liberal province in Canada. I don't see many people in this space that are really gunning for an outcome, because most of our outcomes are not transition.
Yeah, I mean, I think one of the interesting points here is that if you look at the statistically, there are a lot of anecdotes out there about people who have gone through transitions and then later regretted it or felt that they were rushed into transitions. And those tend to be very they tend to get a big media splash. And I have no doubt that their experiences are awful, and I feel sorry for anyone who has to experience that sort of that sort of outcome. But if statistically speaking, particularly with the more recent research from the Netherlands and elsewhere in the world, you see that there are very few people who have that experience. It's a very small minority of the patients who feel that they were rushed into a decision one way or another. And certainly, if you read the guidelines from the World Professional Association for Transgender Health, which is what most clinicians, from my understanding, use, WPATH, then they don't support the idea of rushing someone into care. And again, I have no doubt it happens. It happens in every specialty. You regularly see people who have regrets about surgeries. Pretty much any surgery, even immediately life-saving surgery, you will have people who will later sue their doctor just for performing the surgery because they believe it was unnecessary or it was inadvisable. And the real question to me is how much of the distrust is valid, and I'm sure there are cases where it is valid, and there are clinicians who have done the wrong thing. People are people, and there are always people who do the wrong thing. And how much of it is unreasonable? And we know that some portion of it, and I would say, based on the evidence, the majority of the distrust is perhaps not the fault of clinicians who are attempting to do their best in an uncertain environment. And I think, obviously, there's an issue here because it's a very polarized discussion, and this is certainly what Adam was alluding to. You get people calling each other murderers on both sides, or I think someone very recently commented on a very broad and innocuous statement that I made that everyone who is supporting forced sterilization should be hung. So it's not that I'm not going to say that anyone in particular's fault, but I do feel that statistically speaking, we can say with a fair degree of assurance that the majority of patients who undergo gender-affirming care don't regret that experience.
But I'll let Adam probably wants to push back on this a little more than I do. But...
Yeah, I'm just a bit curious about, what these studies are, what the size of the sample, like what was the sample size here, when did these patients undergo care? Because from my understanding and, from reviewing your interview with the other doctor from the first part of this episode, it seems inconclusive whether or not transition is beneficial or harmful to a patient. And from that, I would infer that, we don't fully understand the risk of transition regrets. And
So-
just one last.
I would say, yeah, this is a very interesting point, and I think this is what Laura was talking about at the beginning of the episode. So there's a difference in context between a low certainty of evidence that a treatment improves an outcome, and simply the asking patients questions about their experiences or reviewing people's experience. So we are uncertain if providing gender-affirming care, or when I say gender-affirming care specifically, there is a great deal of uncertainty about the impacts of puberty blockers, hormone therapy, and mastectomies or surgeries in general for young people. There's less uncertainty in older people because there is a randomized trial that was run in Australia in adults who are mostly in their mid to late 20s. And because the quality of the evidence is very low, there are generally few control groups, and absolutely the studies have been very limited, partly by design and partly by, I think, just a lack of ability to conduct better research, or perhaps funding. I don't know. There's all sorts of reasons people have given for the studies being limited, but we do not know if giving the treatments necessarily results in a better mental health outcome than not giving the treatments. On the other side of the coin, you've got quite a lot of follow-up studies. So the biggest such study was in the Netherlands, which used a linked to national database to assess whether people continued with their puberty blocker and hormone treatment into adulthood. There have been a range of survey studies. There's the I mean, retrospective study in the United States asking older people who've transitioned whether they ever detransitioned or regret their care. There's another study in the United States which looked specifically at one at military people receiving insurance through a military organization. Oh, sorry, Laura, were you?
Gideon, like part of the challenge is, and like I said, like I'm clearly like I'm a trans person. I'm very pro-trans, and like like I'm a good outcome. I recognize, and I know lots of other people who've had good outcomes. And including many people who started their transitions in their youth. One of the challenges that we see is that people are aware that like a lot of the studies that were done looking at things like regret or long-term satisfaction were done in an era where the patient population is different. Now, you're an epidemiologist, I'm an epidemiologist, and we both recognize that when the epidemiology of a disease changes, that there is a possibility, and we have to be open to the possibility that the natural history of that disease changes, or its response to therapy changes, or the risk of complication changes. And I think it goes with that argument, and maybe there is an argument you can make, that there has been a significant change in the demographics of people presenting for care compared to when I transitioned, let's say 25 years ago, to the more recent era. And we run into issues of generalizability.
Just make sure that that extends to all outcomes, though. That also extends to research on what percentage of people transition, what percentage of people go on to continuing. We've talked about this in the previous podcast, that my experience is that a lot of assigned female at birth kids who come to me with gender questioning leave this world female. And much more so than the assigned male at birth kids do.
Yeah. Sorry, Adam, you're...
Oh, sorry. No, I interrupted.
Yeah, but so I appreciate you're saying that now. But one of the there's a difference between you're saying that and that actually being published. So because the data environment right now for sort of the modern transition cohorts is very sparse, in the sense that we're all making a lot of suppositions about how people do based on our clinical experience or on people who are more gender critical, or more people who maybe are trying to restrict or ban gender affirming care for children, or more basing it on anecdotes of harm, sort of the stories, and often the very compelling stories of detransitioners in the media. So how do we so how can we?
I want to build up on what you said, right? So obviously, and just for context for anyone who's watching the podcast, right? So there's been this huge shift. Previously, people who presented for gender affirming care as youth were mentally stable for the most part. They had shown signs of gender dysphoria since they were very young. That was fairly stable. So you could feel fairly certain for the most part that the gender dysphoria was a persisting part of their lives that they would, probably experience for most of their existence. And then, of course, in the early 2010s to mid 2010s, you had this spike in female patients who very suddenly decided that they were male in their early adolescence without having a history of gender dysphoria, and often they came to this realization in tandem with their friends, which suggested that there was some degree of social contagion at play here. Now, on my end, the question that comes to mind here is that if this cohort of new patients, they're a relatively recent phenomena, they've only been around for 10 years, how quickly does it take for someone to begin to experience regret, right? So let's hypothesize like on average, let's say 5, 6, 7 years. Well, I mean, there's a significant portion of people who have received, gender affirming care under this new paradigm, as this new type of patient who haven't yet had time to develop feelings of regret, right? And they're not captured by current studies. Now, I mentioned earlier about building trust and what needs to be done to build trust amongst gender critical folk. I think the conversation we just had right now is an example of where things can be improved, right? So Gideon, you mentioned, for example, that study where a survey was given to adults, transgender individuals, and they were asked about their experiences. Well, I mean, like if you've transitioned for quite some time and you underwent transition, before the nature of gender affirming care changed so dramatically, then maybe your survey results aren't going to be relevant to current practices. And so I think it's important for advocates of pediatric gender care to flag these limitations if they want to win over their their skeptics.
Yeah, look, I agree. I think that that particular study does have limits, and I think I can cite a range of research that supports the position that I was taking earlier. It's one study, but I do think it's important when we're discussing sort of the evidence and the area of care. It's important to be consistent about what things we know are, well, what things are proven from an evidence-based perspective and what things are highly speculative and at times just sort of, I wouldn't say myths, but they are the opinions of a particular group. So, for example, you mentioned, Adam, that we have a new patient population, and that is 100% true. The previous patient population was almost exclusively assigned male at birth. The patient population now increasingly at 60 to 70%, depending on where you go, turning up at gender clinics is assigned female at birth. However, there are a number of things that I don't think are necessarily based on evidence. So, for example, the idea that firstly, the earlier patients who were treated at gender clinics always had consistent and long-term gender dysphoria. It depends on which clinic you're talking about, but certainly in the 80s, in the 70s, the things that could get you sent to a gender clinic, and this is based on the studies that these clinicians published at those times. The thing that got you sent to a gender clinic was a significantly lower bar, I would say, or a significantly different bar. So, for example, one paper describes seeing boys who were displaying doll playing and dress wearing symptoms.
Yeah.
That's the symptomatology. They didn't necessarily need to be expressing any desire to be the alternate sex. They were just expressing effeminate behaviors, and the treatment paradigm was expressly to eliminate those effeminate behaviors. So I think prior to sort of our modern understanding of gender dysphoria, there was a broad diversity in the patient cohort, and it's almost entirely incomparable to I agree, entirely incomparable to the sort of person you're seeing today. And then the people who come into the clinics today, many of them, they say that they have experienced gender dysphoria for a very long period of time. If you ask in surveys, however, many of the parents believe that they are experiencing those symptoms over a very short period of time. And I agree that there's a big mismatch there, because certainly in the earlier situations, in the earlier studies, you see that parents believed this was happening for some time. In the modern
But in any of
period,
these
that's
studies,
not true.
yeah, in any of these studies, it only goes so far, because
Yeah.
what we're really talking about is recall and response biases, like people telling people either what they think, and sometimes that's going to be influenced by what people want to hear or what they think people want to hear. And any of us who are parents, and I think that probably accounts for. I know you're talking about our families a little bit earlier. Knows that we don't always know what's going on in our kids' minds, and we also all have our hopes and aspirations and dreams for them as well, and that can often influence how we answer, how we answer survey questions. But what it really comes down to is what we're talking about is no matter what paper we quote. The state of knowledge about what is best or what works or what doesn't work for children who are dysphoric is relatively sparse. And I sort of agree with the broad contours is that we don't have a lot of certainty about what works and what does, or what works in certain groups of patients, or what predicts who's likely going to have a good response to, let's say, a gender affirming care intervention. We know that these can work. And we know that sometimes, and we don't have a good number on it because it might be changing, is sometimes they don't work so well, or that sometimes people have.
I do think your interview with Dr. Guyot and some of the issues with the evidence have come up in this sort of way in which it was almost like gender care was under the radar, and they didn't do the necessary research that one would do if they knew that scrutiny was coming. It's almost like a retrospective we have solid evidence, and then you go point at it and you do the meta-analysis, and even well-intending people who really want to defend trans care, if they do an honest meta-analysis of randomized controlled trials or even the grade of evidence, it's pretty sparse. Because for a really long time, it was between physicians and their patients. And that conversation has shifted. But I do have a lot of experience in this arena because, of course, I work in psychiatry. And I can't tell you how many times a child tells me something that they've been doing or not doing for a really, really, really long time. And the parent's view is very different than that, whether it's stealing, whether it's drug using, whether it's whatever it is. Kids are really good at hiding things from parents, and kids typically, especially kids prone to internalizing disorders, which we know are disproportionately affecting people who are non-binary and gender non-conforming, don't share their concerns. They actually don't deal with it until it's a major issue. They deal with it internally. They don't express it until it's a major issue. So this is not unique to medicine. Medicine is prepared to handle this. Psychiatry does this all the time. We sit down with families and, I'll have that conversation. I'll get the adolescent to encourage them to open up about what they've been doing. And as soon as the parents hear the story, they become advocates, whether it's for depression treatment or for drug treatment or for gender affirming care. They typically come to the side of their kid once they understand what their kid's been going through.
But one of the things that, and this came out of our conversation with Dr. Guide earlier, is we talked about sort of gender affirming care, part of it came out of a conversation we were having about trying to find analogies about decision making, because you're right that in many, whether it's psychiatric disease or medical disease, we're often faced, especially in pediatrics, making decisions in relatively poor data environments with a lot of uncertainty.
I have a perfect analogy.
Yeah, but for pediatrics, I mean, for gender affirming care, it's a little bit sui generis, in the sense that it's hard to find a perfect analogy. I know we've talked about theoretical analogies, but nothing is perfect. But the fear that often people have is that we are putting people on therapies that are highly consequential. I'm not going to say they're good or they're bad, but they're highly consequential and often partially or completely irreversible. And where there also is a concern about path dependence, that once you start on something, there is going to be a tendency to want to commit to that path. Like, no one wants to look stupid by saying, I decided to do that. I made this major decision that was supposed to be made because this is something I felt for all my life. And now I'm thinking, like, maybe not, maybe I should, maybe I shouldn't. And where these therapies, if you follow them to the end, that do result in obvious changes, impacts on fertility, impacts on how you live your life. As a trans person, I can say this it makes it very difficult in a lot of ways. I joke about this with my husband that, the dating pool as a trans woman became infinitesimally smaller than it would have been if I hadn't transitioned. These are just facts. And these are consequences of decisions that we make. And our kids, when we talk about children, and even parents who want what's best for their children, when you're dealing with something that is this consequential, do we have an added responsibility as clinicians to, or at some point, what's happening, do governments have a responsibility to step in and saying, hey, you're doing something that's highly consequential and maybe doing it in a lackadaisical fashion? What are the kind of things that we can do to prevent this, or at least to reassure people, before embarking on such a path that's such a consequential decision?
I mean, this is a point actually where to pick up on something Adam was raising earlier, I disagree with the current WPATH guidelines to some extent, because I think that one of the main things that you can do is to run clinical trials. And I think that's usually the first point of call when in medicine. And I think there's an understandable antipathy towards clinical trials from the community, because the belief is, and I think in part it's based on a misunderstanding of kind of current clinical trials and how you can run a more innovative clinical trial these days. But in part it's based on this idea that the evidence is clear that anyone who wants puberty blockers and hormones should immediately get them, and that will be the best choice for them long term. And I think that is as Dr. Guy, as you were discussing earlier, Laura, I listened to as much of the interview as I could. That's really the state of the evidence at this point. And I think that there are trial designs that you could implement that would satisfy both ethical requirements and pragmatic requirements. You don't have to one-to-one randomize people to receive either a puberty blocker or a matched placebo. You could randomize, for example, one example is that the presenting complaint, according to the epidemiological study that the CAS review that York University did for the CAS review in the UK, one of the main presenting complaints for people who were assigned female at birth who were presenting to the clinics was menstruation. So coming in having periods and they didn't want to have their period. You could, in theory, randomize people to either receive a puberty blocker or hormonal contraception that would both prevent the period and both delay the decision about whether to proceed onto a more permanent pathway, and provide some other method to, some other sort of psychosocial support or counseling to see if that was as effective. And I think perhaps, obviously that's not going to satisfy all of the requirements, but you could do like a 3-month crossover trial, or there are many ways you could randomize people to receive these therapies that would be both ethical, practical, and reasonable, and would give you a really good answer as to what the best option was for these patients. And I think, for me, that's a really important thing to do.
And you're right, Gideon, in the sense that probably 5 years ago, it was probably the trans rights advocates who were mostly sort of agitating about that doing a clinical trial was unethical because gender-affirming care saves lives. And what we're seeing now is it's more sort of the gender criticals who are saying, we know these drugs are poison. It's unethical to do a clinical trial. And I know there is.
Yeah, and I mean, I was called crazy for suggesting any RCT was possible by activists on Twitter, by trans rights activists on Twitter. So I mean, I can see that there is a great deal of feeling hard feelings both ways. And I don't want to say that it's going to be easy. Certainly, you would have to incorporate patient perspectives. You'd have to have patient advocates on the team to inform the decision making. But I think it would be possible.
But then, I mean, wouldn't there be problems with patient compliance in this study? So let's make a comparison to early HIV/AIDS research, where, from my understanding, it was undermined by the fact that sometimes recipients of HIV medication would share some of their meds with those who received the placebo or those who weren't assigned treatment because they felt like this medication saves lives, right?
Yeah, absolutely. So this is
Right.
why you do this sort of well, I mean, one way of doing it in the randomized trial I proposed is you could have the hormonal contraceptive provided to both groups, either as the intervention or placebo, and you could use the implanted hormonal contraception, so both groups would just get a little implant under their skin. One would have hormones in it, one wouldn't, and then both groups would also be given injections, one of which would be saline and one of which would be puberty blockers, and they wouldn't know which one they were getting, and so therefore they're masked to assignment, and you wouldn't have that sort of share. Anyway, sorry, there are ways to get around it, in my opinion.
I just wonder if that's practical, given that young patients seem to be fairly well informed about options for care. I mean, like on my end, what I always think back to is, the main book that I read on this, once again, is Hannah Barnes' Time to Think, which was based on, interviews with clinicians. And one of their main complaints is that patients came in having very strong preconceived notions about what they wanted because they read a lot about transgender healthcare online. And they were part of online transgender communities and often interacted with, adult activists who guided them through the process. So I wonder in this case, if you had, young participants and they suspected that they were receiving a placebo, would they be knowledgeable enough about this medication to find some way to circumvent this intervention? Sorry, to circumvent your study design.
I mean,
I mean,
I'll just, as the clinician, facing kids, I mean, designing the perfect study is impossible. Answering every question is not possible. we are not going to get a pure answer to this question probably in my lifetime. And I just have to be, comfortable with uncertainty, because when you design a trial, the more strict you do, the less applicable it becomes, because humanity is not strict. So I will routinely see kids who present with depression and gender dysphoria. So if you do we're not studying anyone who has mental illness, we're only looking at gender dysphoria, you're not going to be accounting for a lot of my patients. So the more strict you get with a study, the less applicable it becomes. The more pragmatic you get with a study, the less definite answers you get. And it's a trade-off. A clinician's job is to interpret studies and apply it to their patient populations. I have seen so many studies on antidepressants. Every single one of those studies excludes addictions from the study. So I don't have very many studies at all looking at people who use substances and have depression, which of course are the majority of patients, especially adults, who have depression. So designing something to be perfect, I just want to see good studies. I want to see studies that answer some questions, knowing that we'll still leave uncertainty on the table, and science's ultimate goal is to pursue the truth.
So I want to just shift the conversation a little bit to the sort of political aspects, which I think are very interesting in this whole affair. So sort of the main reason this story kind of even blew up was that about a month ago, so the studies which were done by McMaster University and sponsored by the Society for Evidence-Based Gender Medicine, or SEGM, we can argue, as Dr. Guyton and I did, about whether they're truly a truly evidence-based organization. But the point is that what happened is that Dr. Guyat and his team, or not all the members of his team, but many members of his team, kind of distanced themselves from the research, and particularly from their decision to partner with SCGM on this research. And Dr. Guyat also sort of came out primarily, as he said, he's pro-trans. He does not believe this. He described this care as medically necessary, which we can all quibble about. And if any of you saw his appearance on Mia Hughes's and Stella O'Malley's podcast earlier this week, they took him to task on that. But he came out as an advocate. And I think this is a challenge many of us have, at least in clinical medicine, which is like, I believe this works, based on, or maybe the better way of saying is I really hope that pediatric medical transition works on balance for kids, even though I recognize what the state of the evidence is. And I know, Tyler, and Gideon, you probably feel the same way. And I know, Adam, you're not a clinician, but you're more skeptical of this. Now, what is it possible, or how does it come across when we people as scientists who are supposed to be dispassionate clinicians also show, perhaps rightfully, that we have a preferred outcome, or we have our that there's a way if the data were to fall out a certain way that would make us happier than it would be if it came out a different way. How do we separate ourselves as, when we're advocating in the public for what we think is the truth? How do we separate, how do we separate out our personal biases in a way that we don't come across to the public as being in the tank one way or the other?
I think it's really hard. Oh, sorry, Tyler.
I personally believe it's better to admit that we're all humans, and one of the cornerstones of science is replication in independent labs and independent studies, peer review, all the stuff that helps us check our biases. We have many scientific ways to check our biases, whether it's publication biases, etc. But there are not really good scientific ways to check for what we call allegiance bias, or, Marsha Linehan is the founder of a therapy called DBT, and surprisingly, all of the things she's ever published about DBT are very positive. We have to expect, people always declare their competing interests, and people are so honed in on pharma interests and pharma this and pharma that. But there's ideological interest on either side. If someone came from SEGM, which I would say very much is not an evidence-based society, they wield evidence the way they wield evidence quite poorly. But if SEGM published a study on it, it would absolutely, a fair criticism would be the authors are biased against gender affirming care. Like this would have to be replicated in another house. Psychedelics, the MAP studies, they're all cool studies, but they're all psychedelic users. And every study that comes out of MAPS and touches MAP funding is probably going to have to be replicated by a non-MAPS team. So this is just a reality in medicine. And I think that people have to sort of give up this idea that researchers are somehow robots immune to bias. It's just not possible.
Yeah, I mean, I think that obviously every single researcher has their own biases, but I think that it's better to look at the quality of the research that they produce, and only reference their ideology when you are trying to communicate to the public. So, for example, on my end, I write often about harm reduction. I wrote a series of exposés about Canada's safer supply experiments, which is essentially where they give out large amounts of hydromorphone to people struggling with addiction with no supervision. And much of the evidence base behind that intervention was really, really bad. Like, we're talking about studies, qualitative studies with about 20 to 30 participants that was being presented as objective evidence of success, right? So but there was no need to refer to the ideological biases of the researchers behind these studies to discredit the studies. One just had to point out the fact that they were just methodologically flawed, right? So if you're battling in the arena of science, I think it's better just to focus on the studies themselves and the methodology. But when you're battling in the arena of public opinion, that's a different matter. And I think that if you want to win over people's trust, it is important to be open about your positionality, because if you present yourself as being an objective, unbiased voice, people simply aren't going to believe you, especially in a politicized environment like this. And so, even if someone disagrees with you, Tyler, if you're talking with someone who is gender critical, you should, of course, be open about the fact that you support pediatric gender care, because someone will likely respect your honesty with them and will be more likely to engage with you than if they believe that you are biased, but that you are not disclosing your biases.
And yes, so I think it's important. I know I do this when I give presentations, and we, as physicians, when we're giving presentations, we're often talking about our financial conflicts of interest, which I do have some. But I also have a slide about what I call my cognitive conflicts of interest, which are this is what I hope it will be true, or this is what I strongly believe to be true, and where I'm, because one of the things we do, especially in areas where there's equipoise, is we tend to be much more critical. Like as someone who likes trans people. And I tend to look at studies that are negative about risks or harms associated with gender affirming care with a much sharper eye, admittedly, than I might do for something that shows positive outcome. And I think we all do this to some point. And I sort of, when I'm doing this, I try to check myself and say, okay, you have these cognitive biases. You should try to be as critical on both sides as you do. Yet I recognize someone looking at my critique is still going to be like, well, you're a trans person, so you clearly have some affinity to studies that show that transitioning is good. The other gripe that Gorgai had is he talked about weaponization of what sort of upset him most about SEGM, and what his rationalization for why he wanted to distance himself is he felt they were taking his research, which he thought he was doing in good faith, that came to a relatively neutral conclusion. And in his line of work, when you get a neutral conclusion, it's sort of, well, values and preferences, what's important to the patients, given a choice of possible outcomes, good and bad, what would they choose based on their values? And he felt that they took this research and used it as a rationalization for making claims before governments, particularly in the States, to rationalize bans. Now, I recognize SEGM will say, hey, we're just presenting data here. Governments can decide what they want to do with it. But he felt one of the concerns he had was that they were using his data to advance a political goal. Now, I push back on that, because we all do research. People are going to use it as they wish to be using it. And while I think we can comment and say, yes, I don't agree with how these people are using it, data wants to be free, and people are going to use it to some extent as they should. Now, my question is there ever a place where it is rational and reasonable for a government to intervene on how care should be allowed. So to take it out of the hands of physicians and their patients, take it out of the hands of independent regulatory bodies, and sort of say, you know what, this is how people practice. It's so uncontrollable, or that it's so dominated by bad interests that we need to step in and do something, which is obviously what's happened in the UK and what's happened in much of the US. Is there ever a place where this is rational? And in your opinions, has it reached this for pediatric gender care? Now, I'll start with Adam, because I know he's probably the one who maybe is most predisposed to this argument.
I mean, look, I can make the argument that yes, it's rational, and I can use the harm reduction space as a case study here because that is an area that I know much better than pediatric gender medicine, right? So, just to give some context, once again, safe supply is an intervention where you prescribe someone who is in serious addiction, let's say maybe about 10 to 14 in BC, 8 milligram pills of hydromorphone every day with no supervision. In Ontario, it's more about 20 to 30, sometimes 40. And the problem here is that many of these pills are diverted. And now there are multiple studies showing that this is the case, right? And that's bad because these diverted pills end up in the hands of opioid naive users who then develop addictions and then eventually escalate to fentanyl. The problem here is that these prescribers don't believe that diversion is a bad thing. They believe that diversion is actually a positive side effect because it floods the community with safe drugs, which can displace illicit drugs, and that's never really been proven to be true. So in this case, you have ideologically motivated clinicians who are supporting a bad intervention that has a poor evidence base and has significant social harms. And they are blind to these harms because they really want this to work, even though it doesn't. In this case, I can see there being a very strong case for government intervention. Now, does pediatric gender care, is that where do we see the threshold being met there? I don't know in Canada because I'm not very familiar with the current situation in Canada because most of my writing on pediatric gender medicine is dated for about, let's say, a year and a half to 2 years ago and was mostly focused on the UK. But if one can show that people who are prescribing puberty blockers or who are handling pediatric gender care have a really strong interest in pushing people into transition, regardless of whether that youth seems, whether that seems appropriate or not, then I think in that case, of course, there should be an intervention. But the problem is that that's so hard to prove.
Yeah, I think it's an interesting question because, so is there any situation where the government should step in and regulate what clinicians are doing? Absolutely, 100% yes. There are many such situations. One good example was in Australia during the COVID-19 pandemic. After ivermectin had been proven to be ineffective as used against COVID-19, there were still so many clinicians prescribing it for COVID. Oh, sorry, I'm getting interrupted by a small person. One second.
I'll jump in and save you Gideon. Definitely, the regulators serve an important role. We have what a great interruption. We have a really strong role for regulators. I am not anti-regulation. I do think but I'll push back a little bit on what Adam was saying because in what you've done, what you've expressed so far about safe supply and harm reduction, you've already shown a bias that qualitative research is not really good research, when of course qualitative research can be very good research. There is considerable concern about safe supply, like real legitimate concern about what's being prescribed and diversion and those types of things. But I think there was a bit of a caricature on what what clinicians in the environment are believing and thinking about the medication they're prescribing. Like they're not worried about diversion. I'm a psychiatrist, we worry about diversion all the time. Biases can creep into these things. Where I think that we are with transgender care for kids is very much in the role of, I believe in Canada, we have experts who are doing this very well. I know my own centers. I know what's going on. Is there a role for oversight? Sure. I actually generally welcome oversight. But what's happening in Alberta is literally the weaponization of Guyer's data. This is exactly what the word weaponization means. They're taking what is an evidence-based conclusion in the language of evidence-based medicine, and they're flagging it to governments and say, haha, look, it doesn't even work. And that's weaponization because that is misinformation. That is not what the study says. The study does not say it doesn't work.
Yeah, it's the difference.
But that's what's being given.
It's just saying something doesn't work and saying we don't know.
Weaponization is taking something that was done with a purpose, using it for another purpose to attack someone. And that's exactly what's happening with the science on gender affirming care.
But is the Alberta government saying conclusively that this doesn't work, or are they just simply saying that there isn't enough evidence of benefit, and given this lack of certainty, we're not going to allow the intervention to happen?
We're not going to allow it to happen. So that is not taking a position of neutrality like the position of neutrality that's coming out of the evidence. That is
they're not misrepresenting the evidence.
But they're turning a neutral conclusion into a non-neutral position.
But I think
so.
I think the reason they're doing that is because, if you are not someone who suffers from gender dysphoria, and if you're not someone who's a parent watching someone suffer from gender dysphoria, when you look at what are the potential harms, or maybe not harms, consequences of going on therapy, you're talking about things like loss of fertility. People look at you as you're turning yourself into someone who's going to be an outcast in society, who people are going to be, where your life will be more challenging. And they see these as harms because if you're cisgender and you're not suffering from gender dysphoria, the thought of losing your fertility seems like a major loss. And the thought of being an outcast from society seems like a major loss because it's not being held against what it feels like to suffer from gender dysphoria. Now, I'm someone who suffered from gender dysphoria. And while my fertility was important to me, and not being an outcast in society also important to me, I expressed a preference for not having gender dysphoria over those two things. But people who are making policy, who generally are not people with gender dysphoria by and large, put a low value on what it means to suffer from gender dysphoria and a high value on losing your fertility or losing your place in society. And so I think it comes back to that value and preference category that, we recognize that people's values and preferences are different. And the people who are probably best positioned to judge that in any given situation are the people suffering from the condition. They know how bad their dysphoria is. And they also know what they would do to get out, what they would give up to get out of it. Now, we can say that calculus is maybe different for children because they don't have the same capacity to understand what it means to lose your fertility or what it means to be an outcast from society, but this is generally how we frame these decisions in terms of how we provide care. Adam, you look like you want to jump in.
Sorry.
Yeah, I ended up getting you go ahead.
Yeah.
I think what I was going to say before I had a delightful interruption. And I think it ties into what we were discussing is this idea that there's so many kids getting these medicines too often because of clinicians who have a specific perspective, and there's all this bias in clinical care, and I agree with all of that. But I think the evidence generally shows that this wasn't happening and hasn't really been happening overall. So if you look at the York review, the York epidemiological study published as part of the Cass review, of the children who were referred to the gender clinics in the UK, of the children who were seen at least once, fewer than 10% got any medical treatment, and only 4.7 were given puberty blockers at any point in time of the cohort that they reviewed.
This is
service.
Yeah.
Yeah, the GIDS. It's gender identity disorder. Yeah. And this represented a tiny, tiny fraction of the pediatric population in the UK. I think it was less than 5 in 10,000 children were ever referred. And some of the reasons for that are complex. In some cases, it was just because of the incredibly long wait times on the NHS. So some children were referred at the age of 16 and then just aged out of the service before they could get any medical treatment, and then they went to see adult clinics. But at the same time, I think it's fair to say that, at least in the United Kingdom, the treatment pathway was a very long period of assessment before any medical treatment was given. So I understand that there are certainly cases where this hasn't happened, but the general trend of the evidence is that the majority of kids got quite a lot of assessment before they were even offered the possibility of going on meds.
And I think that's a big gap in the data, though, because like in the UK, where there's a National Health Service and everything's coming through this one path, it's one thing. And I don't know, if the situation's different in Australia, but, in Canada and US, I think one of the challenges is there is this incredible amount of variation in care, depending on whether you go to, or there's a perception.
But I mean, like in BC for kids, there's really only one or two places to go. Like there's not a whole bunch of gender clinics in
but
BC
I guess,
for
but when you're
kids.
talking about like the States, for instance, there were definitely anecdotes of people going to primary care clinics or to Planned Parenthood or things like that and getting access to therapy, or using nurse practitioner services and getting access to therapy with very little screening. And
We all agree that rushed service is bad service.
and so when you see this
Yeah.
variation in care, we don't know how much it happens, but the fact that it does happen is enough to trigger concern responses. Whether it's 20% of the people, whether it's 2% of the people, we don't know. But it's enough. But when you get these anecdotes coming up, especially of detransitioners who are saying, "I went to X and they gave me a testosterone shot on my first visit without having any mental health assessment," and then you also hear stories, even in places like Boston Children's, where it was reported that because of the huge demand for services, they felt they needed to be more expedient in terms of how they provided them. So these are just the reality, and I'm sure they all meant.
I would posit in Canada that pretty much everyone who goes down the pathway of puberty blockade and hormone therapy has consulted an expert endocrinologist. I don't think there's a lot of family doctors attending.
There was actually a CBC, French CBC investigative report that showed that that wasn't the case, that there was some young girl in Quebec who, I think an actress who played a 13, 14-year-old who was able to get hormone blockers, like puberty blockers just like this.
Yeah. So
Yeah.
that
Well, I'm not saying zero. I'm not saying zero. I'm saying, by and large, the pathway
but it
is.
highlights the power of the anecdote in this,
Yeah.
and I think I don't know whether we talked about neuron, or it says something along the lines is where data gaps exists, anecdotes will happily fill that gap. And the anecdotes, what people want to hear, all you need is that one or two times the things where someone says there's a bad outcome to create this huge hue and cry.
There is really something that I wanted to get out, though, in all of this, is that there is also quite a generational difference. So even Laura, you're a trans person who is from a different generation of trans kids in 2025. And we have a tendency as older people to look at the younger group and say, "You're doing it wrong. That's not how it's supposed to be done. We did it right. You should be doing it what we do." And typically, the generation that replaces us old fogies proves us wrong. So we were told lots of things that we weren't supposed to do, and we did them anyway. And now this is our world, for better or for worse, and they will too. I think, given where things are right now with the evidence, the best evidence we could immediately produce that we could do feasibly would be to be asking kids in these positions what they want, asking recently transitioned youth, asking youth who are gender questioning what they want, because that data could come out a lot quicker than the types of really, really good data that even like the processing that Gideon's study would have would be emails back and forth for a long time. So
but I disagree with that, Tyler. I think you could today conduct a linked epidemiological analysis that examines some of the hard outcomes.
No, I was talking about a controlled study. Study. But...
You can't do an RCT, and that is a problem in the areas that no one has yet done a large cohort study. Like in the Netherlands, they could do it very quickly because they've got good linked data in the country. You could look at hard outcomes like hospitalizations and suicide rates. In Finland, they did do a linked cohort study, but they didn't compare children who had gender dysphoria and were referred to the clinic and got treatment, and those who didn't get treatment, which was the key question. If you I reran their numbers, and if you look at the statistics there's about a 70% reduction in suicide rates for children who received gender affirming care to those who didn't receive gender affirming care who were referred to the clinic. Obviously, that's not necessarily causal, but I mean, so it's definitely possible to do better research in this area. I think part of the problem is that most of the research that's been done has had a very, very obvious political slant, and there are very few good studies.
Tyler, I'm just going to push back on your idea. You seem like a great guy, but that kind of approach to policymaking seems somewhat unwise. Let's go back to the ivermectin thing. Imagine if you asked people, you said, okay, do you want ivermectin? You say yes. Okay, we should just give it to you, right? Like, just because someone wants something doesn't mean that it is the appropriate medical intervention. And if you're going to ask people who are newly transitioned, they're all going to tell you, well, most of them are going to tell you that they're happily transitioned because it takes time for regret to set in, right? So I don't see how this could be the basis for responsible policymaking in this area.
Medical decision making is looking at potential benefit and potential harm. So the harms of ivermectin are low. The true harms come when you don't seek out true treatments for, like, you don't take the vaccine or you don't isolate yourself because you took ivermectin. Ivermectin is a relatively harmless intervention. Most science-based people aren't anti-ivermectin because it's harmful and people shouldn't be taking it. It's because, well, it's not that limited resource, but it is an effective anti-malarial and it's an effective anti-parasite. It just doesn't work for COVID. So, the benefit of doing it is low. So invoking, the two things aren't similar. Because when I'm dealing with a situation, and I have a perfect analogy. I am one of the only physicians in BC who's ever given electroconvulsive therapy to people under the age of 18, and talk about an area in which there is no randomized controlled trials. There are very, very few randomized controlled trials in adolescents, but I'm dealing with a child who is catatonic and extremely sick. It's a matter of life and death. We do think that ECT helps when benzodiazepines don't. We have a really good reason to suspect that in adults. And I have to sit with a family and work with them the decision, do I give electroconvulsive therapy to my 9-year-old child who is in catatonia right now or not? And I do it with
even though there's no evidence.
A complete dearth of evidence. Yeah. I do it from some basic clinical experience. I have on my books, I have a total of N = 7. And it certainly is something that I can read about in the research, but nothing definitive. And so if, in my case, I present this to the family as a true, I don't know what's going to happen, but this is something we can do. Here's the benefits that are reported from it. Here's the harms that are reported for it. What do you want to do? And it is life-altering to the kid. We know that there can be severe side effects to ECT. We also know that there can be really severe side effects to not treating severe catatonia, including death. So we are literally dealing with something that we feel is very much life or death. So if there were a big inquisition right now on should we give ECT to kids under the age of 18, the government may, rightly, with all of the anti-psychiatric fervor and all the mistrust for doctors, say, you know what, we're going to pass a law right now. No ECT for kids under the age of 18. And I know kids that would have died because of that decision. When you give ECT in these cases, usually the turnaround is within 24 to 48 hours, and it's quite life-saving. So can we ever develop the data on that? No, we have a whole bunch of case reports in the literature. That's all we have.
So this is one of the, I want to just pick this point up because, like, when I've talked to people who are very much against the provision of gender affirming care, who want it banned, I present with them and I say, okay, like, I understand, like, the evidence here is not strong, but you have a child and you say, well, they should be given psychological interventions because this is a disease of the mind, and we should be treating these diseases of the mind with psychological interventions. And I say, okay, that makes sense. Let's do that. And then 6 months later, and this is your kid, and you've been giving them all the psychological interventions in the world, and they're getting worse. Now what? Now what? This is your child. Do you want to try something that's out there because this is your child who's deteriorating in front of you, or are you going to stand in your position and say, well, I said psychological therapies. We're going to continue with these psychological therapies, which may work in some people, but aren't working in your child. Do you want options off the table? Whatever those options are, even if they're high consequence interventions, like pediatric medical transition might be considered. I have yet to hear from a person who's more critical of what exactly they do in this situation, except falling back on, well, it's a moral wrong to transition children, and therefore they're just going to have to learn how to suffer, like we all do, and that's sort of, so that's always been my argument against sort of outright bans, and I'm okay with people considering psychological therapies or less consequential interventions first. But what do you do when things go wrong? And this comes back to our conversation with Gordon today, where I said we spend so much time looking at what works, and we don't spend enough time talking about, like, is this working and then what? So is there a better way that we can have this conversation to take people who are sort of skeptical and sort of reframe the conversation, not like we think this type of therapy should be used in all patients, but we should have these kind of therapies available, because what if your child might need this one day?
I think the question here is, what are the harms of not providing pediatric gender care, right? And people always say, well, the kids will kill themselves, but that's proven to not be true. So I think the prudent choice here.
I'm right in my area.
There's no evidence to show that it's true. Sorry.
Yes.
Important distinction, subtle important distinction. Yes. So there's so there's no evidence to show that's true. So in this case, would it not be prudent just to wait a few years to see if the gender dysphoria resolves?
So this is my area of expertise is in suicidology, and Gideon was referring to linked studies where we can actually look at things like suicide outcomes. We can't generally, it's very hard to design the type of causal answers, but we do have evidence that gender affirming care reduces suicidality. Not talking globally of pediatric gender care and this, I'm talking just globally pictures of gender affirming care, that it reduces suicidality in terms of suicide thinking and suicide attempts. Suicide deaths is a lot harder to study.
I would say actually the Finnish study, if you recalculate the statistics and run the analysis that they didn't run, does provide evidence that there is an association between provision of gender-affirming care and a reduction in rates of suicide.
The burden of causality.
Yeah.
You cannot infer from that gender-affirming care prevents suicides necessarily, because there's obviously going to be major differences between children who managed to attend appointments at the Finnish clinic and receive gender-affirming care and those who didn't. But the current best evidence, in my opinion, would be that the children who receive this care tend to commit suicide at lower rates than those who do not.
I certainly think that it's barbaric to wield death in a parent's face. Like, if you don't choose this, they can die. Like, I've heard that sort of, would you rather have a dead son or a live daughter? That's barbaric talk. That's not the way that clinicians should present information to parents. That's the way activists might phrase things, and I have lots of criticism for what activists do and don't do. When I lay out what could happen if we give ECT or not to a kid, I list death as a possibility for both outcomes, because people can die with ECT and people can die without ECT. So wielding death is generally a barbaric thing to do. I saw this, I got onto the public health scene because of the way that people were wielding child suicides in the should kids go to school or not debate, which was extremely barbaric. It was a very cynical wielding of pediatric suicide. And it reached all the way to Donald Trump. So I'd rather us not look at outcomes like death when we're talking about this and just think about suffering, because the condition that presents to me is a suffering child, and the condition I seek to relieve is the suffering in that child. I can't know the outcomes. And even if I had a really good randomized control trial that said that 70% of people who receive gender affirming care go on to not die by suicide versus, whatever, I don't know what's going to happen for the individual in front of me. Randomized control trials will never tell me what's going to happen for the individual in front of me. So if we focus on suffering rather than death, I think that's a much better thing to think about.
I mean, it's also worth noting Tyler's perspective comes from the area of psychiatric medicine. Virtually all psychiatric medicine is based on self-reported scales of mental health, of how people are feeling. We do have large linked studies that look into hard outcomes like death and hospitalizations, but randomized trials can almost never assess death, because death by suicide, even in very high risk populations, is much rarer than you might imagine. Yeah.
But
anyway,
this comes back to that point that I was making before, which is that you're right. We don't know who's going to respond, and we don't know who's not going to respond. We don't know who is going to get worse, and we don't know who isn't going to get worse. And as a clinician, like I treat inflammatory bowel disease, and I'm faced with the same situation. I've got drugs that might work, they might not. They might have side effects, they might not. But what we do is we try something that we think at least has some evidence of efficacy, and then we monitor. And we say, is this working? If it's working, we continue. If it isn't working, we switch up to something else. And one of the things that's nice about my field right now is that we have lots of options to switch to if something isn't working. And similarly, you could make that same argument for gender care, whether it's pediatrics, is that we try something non-interventional at first, or we talk to people and see what they want, and we reassess and we say, is this working? If it's working, let's carry on. If it's a psychological intervention, this patient, like you said, let's say we adopt a wait and see approach, as Adam alluded to, and we check back in 6 months and it's like, hey, are you feeling better? Are you doing okay with this? Yes? No? Yes, let's carry on. No? Maybe let's try something different. And the more things different, the more we leave on the table of things we can try, gives a better gives people more options to find that thing, whatever it is, that works. And I think it goes both ways. If you start someone on puberty blockers and you come back in 6 months and this person's deteriorating, it's like, maybe this wasn't the best path. And to take these decisions from the individual level, as opposed to, unless there's sort of clear, overwhelming evidence of harm over benefits, to leave those options on the table just makes sense to me as a clinician.
Yeah. And I think that, as I was saying earlier, I think overwhelmingly the data shows that sort of careful assessment was what was being done. But perhaps, and this is, I guess, is more of a political framing or a sort of public trust thing, perhaps there should be legislation saying 6 months of assessment prior to initiation of puberty blockers and hormones. I actually don't know the legal system in Canada and how easy or difficult that might be to do. In the UK, the government essentially banned puberty blockers outside of clinical trials and then still hasn't initiated the clinical trial, so they've effectively banned puberty blockers indefinitely. And hormones are now restricted extremely tightly and almost never used. So it's a complicated question about how exactly the government should step in when there is a low certainty of evidence. And I think Dr. Guy actually had a very good perspective on that. I think his public statement was very reasonable.
All right. So I really wanted, I know we covered a lot of ground here, and I want to wrap up soon because I know we have our guests here are all over the world in different time zones, and people have different things that they need to get off and doing, whether that is eating, sleeping, and working, or whatever. And I do want people to be able to get on with their lives. Is there any sort of last words anyone has before we wrap up?
That's a good conversation. I think Dr. Guy would have been really well served to remember that, science is political. Like, I think he got dragged into science being political, but it's a pretty 2000 thing to know that your work goes out there and is used by people.
Yeah, and I think he's been used to sort of giving presentations to scientific audiences who kind of want to hear what he has to say and trust him in his word, and entering a space where he's having people who are coming at him hard with different political agendas, I think was even at his stage of career. It was a fairly new experience for him. But yeah, no, I think it is a challenge when you realize. I don't think he quite recognized what he was getting himself into when he signed on to this. It's fair to say.
In terms of last comments, I would say that if gender clinicians want to rebuild public trust, it's important to spotlight conversations like this, where you have clinicians openly discussing some of their concerns about a lack of certainty with the evidence base, about the trade-offs of providing certain interventions over others, and basically showing their doubt and their humanity and their empathy, because that is relatable. And I think that that would be a more productive image of gender affirming care than the activist image that people currently see.
Yeah.
So instead of having activists saying, do you want uh, do you want a dead daughter or a live son? And the science is settled, and anyone who disagrees is a bigot. I think replacing that image with, these kinds of conversations would tone down the rhetoric here and would help everyone understand that no one is trying to harm kids, or at least I would hope that no one is trying to harm kids. Um, and that through conversation we can move forward, and there's no need to demonize for both sides to demonize each other.
I agree. And I think, I'm glad that we had like Tyler and Gideon here to talk, but, one of the challenges, I think a lot of people are actually practicing this type of medicine, and I've reached out to quite a few, are afraid to talk publicly about it because they're afraid of two things. One is that their views will be misrepresented, and the second is they're afraid, and not unreasonably so, of death threats and threats to their family and being doxxed and things like that. Because, like, you're right, there's probably a lot of clinicians who could be having these conversations who are directly responsible for the care of kids, but they're feeling a little cowed right now that anything they say might be used against them to justify a ban, like particularly in Canada. Where I'm at, I reached out to a number of clinicians and they're all like, I'll talk to you off the record, but I will not appear on camera and talk about this.
Yeah, it's a toxic environment. I had death threats just last week, engaging in anti-trans and trans debate. And I have many colleagues who are like, why are you even talking about this stuff? And they're just practicing their medicine, and probably very well, but
because I think if more pediatricians talked about this, we could change the conversation, but
hope so.
I understand why they're scared too as well.
Yeah.
Anyways, thank you so much, gentlemen. It's been a pleasure talking to you all and to have, like I said, these different perspectives and to really have a nice nuanced conversation where I don't think anyone raised their voice, even when there was some disagreement, which is sort of exceedingly unusual for any conversation about pediatric medical transition. Thank you guys so much. This was an excellent discussion, and I look forward to talking to you all in the future.
Pleasure.
Mine as well.